I'm Catherine Henry. I'm an attorney here in Michigan. I have sitting with me Dr. Martin Dubravec. He is an expert immunologist here in Michigan. We've been doing several segments so far on various aspects related to COVID-19. We did realize that in the very last one we just recorded, we've had some technical difficulties. So in the event that we're not able to recover that file where we went into all the specifics about some COVID-19, the science behind it, the studies that have actually been coming out versus what the government or the media has been saying is out there, I just wanted to do a very quick recap, knowing that, yeah, this is not going into the specifics of studies and pointing you to things that can get you going and looking and verifying on your own, but just wanted to very quickly summarize the segment that might not end up making it onto Facebook later. So basically, I'm just going to do this real quick and you tell me if I'm right or wrong, but what we talked about is that based on numbers that come directly from the CDC about flu, and the numbers that come directly from the CDC about the total number of deaths, which that part I believe we went into more detail in a prior segment, right? So I think we would be okay. Okay. So hopefully you can go look at one of the prior segments that does look like the file is okay. We are seeing, we're using that data, and then we're looking at the testing that has been done in Hawaii, in California, in New York, and it's starting to happen in hospital systems here in Michigan. It's happening with phlebotomists in Chicago a month ago already. We're looking at numbers nationwide that are showing some very important information. So this is not information that I've generated, that he's generated. This isn't information that is, coming from some conspiracy theory website. We're talking about either actual boots on the ground, doctors that are serving and testing these people directly in mass, or we're talking about government reported numbers. So with those verified sources, I guess you could say, or those trusted sources, my understanding is what we're looking at now is that although we have when we look at death rates, when we look at, okay, so what is scary about COVID-19? In order to figure out how to move forward and how to handle it, we got to know what we're dealing with. We're going to try to figure out the death rate. So how many people get COVID-19 total? How many people have already had it here in the U.S. versus how many people have died from it? And while we originally thought that the ratio between those two numbers was much, the percentage was much higher of people who get it versus people who die from it. So in other words, I think we were seeing as high in Michigan and in several states that it was the nationwide number, the highest I saw was 4% of people who get it die. In Michigan, we've seen as high as 6% of people who get COVID-19 die. But what we're seeing now is that on the one side, the number of people, the total number of people that have gotten it is much, much higher than what we originally thought because of all these tests being done by the thousands, like I mentioned, New York and California and Hawaii and all these other places, that many more people, thousands, huge chunks of the population actually have already gotten the virus and either did have symptoms and then we just didn't know, the medical providers didn't know what name to put onto it, or people didn't even know they were sick at all and they might have just been one of those people like so many others worldwide that just are more of a carrier for the virus and show no symptoms at all. So that number is far greater than what we ever thought before. So that alone would make the death rate go down. But what we're also seeing is the number of deaths reported by the CDC in the entire country is about half. So what you see in the media, what you see on the news every night, take that number and divide it by 2, and that's the actual number of people that a medical provider has said this death is somewhat associated to COVID-19. So just to recap, April 23rd, the data from the CDC websites on April 23rd, on the one portion where they give you provisional counts, that's the one where they have all the pretty graphics, and there's the map of the U.S., and it's interactive, and you can click on different states, and it's what's going to draw you in, because you're like, oh yeah, that's information I can understand. That information, that's all jazzed up. Those are provisional counts, and those counts showed that 46,379 people died from coronavirus in the U.S. as of April 23rd. The same CDC website on the same day, though, if you dig around and go to a different part of their website, shows that by the same day, it's actually, the true number was only 23,358, or half as many people that actually had a COVID-19 death code assigned to them on their death certificate. And important to note that death code being used, 7.1, although it's only supposed to be for laboratory confirmed cases, which would be the medically significant or scientifically significant cases, the U.S. puts right on there, and the CDC puts right on there, that they're actually recording both laboratory confirmed and assumed or likely cases in that same count. So that 23,358 has people that were just merely assumed to have had COVID-19. So just to be clear, so those provisional numbers that make it twice as high, it's because the CDC says right on their own website on these documents that we're just going to grab some numbers of pneumonia, that's not COVID-19, pneumonia numbers, and throw them in to the numbers we're going to advertise and share with the media. So the total number of people we're realizing in the U.S. who have had COVID-19 is much higher than what we originally thought. The total number of deaths of people dying from COVID-19 is actually much smaller than what we've been reported. And in the summaries given by the government agencies. So what that means is that the death rate is so much lower than what we originally saw. So it's nowhere near the 4% we saw nationwide earlier on. Is that correct?
Correct. And we can expect it to be similar to or less than influenza.
All right, so similar to or less than the flu.
So what we're saying is it's as deadly or less deadly than the flu.
Okay. So that's one of the main concerns we've heard, right? Everybody's, well, oh my gosh, you guys are being selfish. You want to open back up your business. You want to go to the dentist. You want to do all these things when you're going to risk people's lives. I mean, this thing is deadly. Yeah, it is deadly. It's just as deadly as he said, or even less deadly than the flu. It's actually less deadly than cancer. It's less deadly than several other leading causes of death in the United States, but we won't even go there. But just comparing to the flu, it's just as deadly or less deadly than the flu. So what about transmission? One of the other concerns people have said is, well, even if you think it's not as deadly so far, the thing that makes this one dangerous is because it spreads so much worse, so much faster than the common flu. With what we went into detail in the segment that hopefully will revive itself and the technology will save us there. But when we talked about the transmission is actually very similar. You went into a lot of specifics that I won't beg you to go into detail again. But we talked about that there's been a variety of testing in the U.S. and in other countries recently that talked about getting more data on how long the coronavirus can stay on surfaces. And that the lowest I heard you say that they were talking about is if you have an average, it's almost May. A lot of areas in the country are already seeing 70-degree temperatures. If you have 70 degrees and you have the virus living on a surface, that it's maybe only going to last 2 minutes.
Yeah, so the Department of Health and Human Services, I think, has a lab where they're looking at coronavirus, and they found that at 70 to 75 degrees Fahrenheit, 20% humidity, and ultraviolet light, like sunlight, the virus lasts less than 2 minutes.
So, and you said, I believe, in our prior segment there, that correlates to, a lot of what we're seeing with the flu. So we've seen other things that it may last as many as 3 days on a plastic surface, but obviously different conditions go into to that. So is there sunlight involved? What is the humidity? What other factors are we looking at there? But all of those things combined, is it fair to say that when we summarize all of it, the transmission of the common flu is very similar to what we know now about the transmission of COVID-19?
I agree, yes. And the difference now is that we can make some predictions. Before, we had predictions based on wild guesses. We didn't have data. But now we can look and say, okay, what's expected to happen over the next 2 to 3 months? Well, the first thing is that nobody knows for certain whether or not we'll have another surge in cases. That's a wild guess. But we do know that the virus so far has about an 8-week lifespan, regardless of the country that it's hit in Europe. And so we can expect it here to have about the same lifespan, and certainly we're seeing that. After our peak in cases in early April, we've now seen a significant decrease in cases, and we know that the virus tends to go away more quickly than it ramps up in a community. So that's very important. And also, when we look at coming into summer in Michigan, we can safely say that the virus is on its way out. Okay? So the question I get often is, okay, how do I go back to work? What about opening up? What about trying to get back to normal? Well, there are a few things to keep in mind. Number one, the virus is on its way out. Number two, it's not more lethal than the flu. So the same precautions that you would have had to address influenza, you should have with regard to COVID-19. And often those decisions will be individual decisions between a patient and their physician as to how mobile they can be. Should a patient on chemotherapy who works at a hospital, should they go back to work? That's going to be up to the patient and their doctor. An elderly person, how safe is it for me to go out of my house? Well, I would say, what did you do during the height of the flu season in your community? The other thing that we can look at is we can look at the numbers of infected patients in our local communities and see. And especially outside of Detroit, we've never had epidemic levels. The other thing is we can look at therapeutics. We do have some medicines. There is some controversy as to what can be used to treat COVID-19. I personally believe that hydroxychloroquine and azithromycin can be helpful. So if a patient does have symptoms and they're at high risk, they could be placed on those medicines. We also look at the whole concept of, if a surge occurs, do we have the capabilities to treat that surge? And absolutely we do. We overfactored the number of ventilators, hospital admissions, equipment that we would need. We've got more than what we need in our communities, and therefore we should be able to handle any surge if that were to occur. But I would say that even if we are considering a surge, a lockdown would not prevent that, because we were never locked down. We were never completely quarantined, and therefore we still had exposure to the virus. Each of us did, just by going shopping, just by going to the pharmacy. And so the virus is not going to go away completely. It's going to be with us, but our response to it can be one of fear and panic, or it can be one that's very constructive and realistic, developing a sort of a risk depending on each of us as individuals, and having that autonomy and that freedom to decide what our risk is going to be. And we now have the data and the science to say that we can make good decisions, sound decisions, and we should really be able to open up fully. A boutique, a flower shop, a restaurant, they don't have the foot traffic that a Meijer or Walmart or Home Depot does, especially with these big box stores having decreased hours. Therefore, we should be able to open up, and we should be able to open up relatively freely and as soon as possible. We shouldn't live in fear and panic anymore with regard to this. Those days are over, because we now have good science and data presented to us by the CDC, by the state of Michigan, that we can make good decisions with.
So you would say that none of the plans presented by the House or the Senate or any other plans that you've seen that would require stages or phases or waves of different businesses opening, that wouldn't be needed, that we could go back into our normal lives of going to the gym, playing sports, going to church, opening up your shoe store, all those things, that we don't have to do those in different stages, we could go ahead and go back into life. The virus is going to do what it's going to do, and those who are immunocompromised or elderly, they should discuss that with their medical
Yes.
providers and
Mhm.
make the decisions for themselves about what risks they're willing to take or what they would like to do. But for the rest of us, we can feel comfortable and confident in going back out into the world, and that we're not going to have this huge surge in everyone dying around us. Is that what you're saying?
Absolutely, absolutely. We should look at it like we do influenza. And the reason why the virus is, why the cases are going down in Michigan, why they've gone down in New York, why they've gone down in New Orleans, is because we have enough people who have gotten the virus and have recovered. The virus has nowhere to go.
Okay. Well, there's obviously much more that we could talk about, and maybe there's future topics we'll find a way to discuss. But in the meantime, I think we've definitely given some viewers some information that'll help them digest the true information straight from the CDC that's out there in a way that can help them reduce their fear and gain comfort and confidence in knowing how to get right back into their lives. So thank you very much for that. I
Thank you.
appreciate it.